I mean, pretty much everyone's going to have a back issue at one point or another in their life. And so it's not an abnormal thing. What's abnormal is when it's, you know, so severe, and then that's where somebody like me or Jonathan come into play, where we really need to help somebody with their issue. But it's definitely one of the most common reason. I think maybe cold or flu or something maybe overtook it as the most common reason to go to the doctor. But anyway, it's up there. It's the most common orthopedic complaint, you know, is that we have back pain. This slide essentially is there to show that it's an extremely expensive thing as well. And it doesn't necessarily need to be, but it absolutely is. Because a lot of times you go to your family doctor, they're maybe not going to know exactly what to do. They don't really get a lot of this training and stuff in med school, and then they're very focused on getting you healthy if you're sick, not necessarily if you have orthopedic complaints, you know, like back pain or shoulder pain or whatever. So a lot of times they're going to either order some very expensive test, like an MRI or something right off the bat, which is going to be probably unnecessary, or they're going to refer you right away to a specialist that's like a surgeon, you know, like a spine surgeon, an orthopedic doctor. And they're also very expensive because that's what they do is surgery. Surgeries cost a lot of money. So that, you know, is one of the main reasons why this is such an expensive thing. Whereas somebody like me, I'm a much, much cheaper option when it comes to surgery or even an MRI. And we can save, you know, a lot of this money by weeding out people who actually need something of that higher nature. 7 out of 10 people with back pain are going to fit into a system that we're using, of course, for classification and that kind of thing, where we can help them. No drugs, no surgery, no need necessarily for advanced imaging. You know, if there was an injury or something very specific, then maybe you want to rule out a fracture. That's inexpensive. You can get an X-ray. But the higher level imaging is what I'm talking about. A whole lot of misconceptions about low back pain. It's probably the least understood area in the body as far as pain is there, what should I do about it? So many different schools of thought out there, but a lot of misconceptions, especially gym related. That's why I kind of geared this toward, you know, like wearing a belt, other things like that that are gonna stop you from having back pain. The first two kind of go hand in hand because that's what a belt does, sort of overtakes like your core strength. So, or it's meant to be like your core strength. Both of those things not necessarily gonna stop this or prevent it from happening in the future. And then this last quote I put in here is that, you know, we want the patient to be independent with this because it's more than likely going to happen again. So if you have a go-to, something you can use to continue with, and you're trying to prevent it from happening again, or if it does happen again, you have something you can do. So the misconception being that I'm always going to need a therapist or a chiropractor or my doctor to treat back pain. Not necessarily the truth. In fact, this is what we're aiming for right here, independent of therapists. So, yeah, it maybe put me out of business or something, but it's more than likely going to give me a reputation for helping people than it would, you know. So anyway, I'm willing to go to that because it's really what is needed most of the time. So here is our entire spine. Left view. The one on the picture on the left is looking at somebody from the side, like looking at me right here. So it's meant to have these curvatures. These are normal. Where we don't want to see a curve is here, when you're looking at someone from the back. That's what that view is right there. We want the spine to be straight. If there's a curve there, that's where you're going to see things like scoliosis. You know, that's where these curvatures happen and stuff here. These are meant to be here. We're meant to have this lordosis. This is like the small of your back, that inward curvature here. And then it goes out in our mid back, that's a kyphosis, and then it's meant to be lordotic again at our neck. So we're supposed to have those curves. They help transmit force throughout our body. When someone has really bad back pain or even neck pain for that matter, this curvature and this one, or if they have neck pain, they can flatten out because of whatever's going on there. You know, nerve really irritated and they're trying to stay away from that nerve, and so they kind of flatten out their back. Or bulging disc. You can imagine if something's bulging back here, you're going to be trying to move away from it, try to give it more space. So we can see that flattening. And that kind of thing shows up on imaging too. Doesn't necessarily mean it's not reversible. Most of the time it is. Unless someone has, you know, just really, really advanced issues. Or they're 70, 80, 90 years old. You might start to lose some of that. So what can cause the pain? I put this couple slides up, to explain what can and what usually is causing pain in the back. But to be truthful about it, I don't really care what it is. It doesn't make any much difference to me what specific structure in the back is causing pain. Because it can be a whole lot of stuff. It can be a nerve exiting. So this is a little close-up view of our spine itself. We have the bones of our spine, the vertebrae. They stack on each other like this. There's a disc in between. Every level, there's a nerve that comes out from our spinal cord. That's that thick yellow in the middle there. These nerves coming out, they're in our back anyway, they're going to our legs. So it gives our legs power, so it gives our skin sensation in our legs. So a nerve being irritated here for whatever reason, a lot of times it's a disc maybe bulging against it, but it doesn't necessarily need to be. That can definitely cause pain. Of course, you can have fractures at any one of these places as well. Compression fracture in the body happens to a lot of older people as they get this stoop position, puts a lot of pressure on the front of the vertebrae. They can get compression fractures, especially at a low bone density, all that kind of thing. These pieces and stuff back here are all kind of weird shaped because they're facet joints of how the two articulate with each other, stacked above, but muscles attach here as well, and they can fracture. A lot of times if that happens, it's going to be a younger person, like a car wreck, horse accidents, pretty common. Gymnastics, weightlifting, they can cause those things as well. Catching a really heavy load in this extended position, all the weight being put on these smaller pieces of bone can get fractures. Then of course we have a whole lot of muscle around our back. But you can sprain your back, of course, muscle-wise, but it's not the most typical thing because really our back is meant to be a stabilized area of our body, and we're meant to lift with these down here, our hip muscles. They're strong, they're meant to be the movers. So, but yeah, you can definitely have local pain in the back from muscle being irritated or strained. So this further explains what's going on as far as nerve irritation and what may cause them. It seems kind of obvious now, but in the early 90s, they're really trying to determine what could be causing pain back there, what takes up space in the back of the vertebral area, and that was what the most common thing was. Disc being compressed, pushing back into this space. See, this is nice and wide open. That's a healthy spine. But if they were to be taking up some room here, now we've got compression of the nerve, sciatic nerve, everybody's favorite thing, when it comes to back pain. Everyone's heard of that. But I added this quote in here as well because this is really how I feel about things as well, that we grade the severity of it, of what's going on, not by how high the pain is, like 0 to 10, but where it's located. So that's, in my mind, the severity level. If you have localized back pain, just pain in the back, maybe even the top of the buttock area, even if it's 9 out of 10, very, very severe pain, that's a much better situation than if you have maybe a little pain in the back, but it's way down the leg, and maybe it's only a 2 out of 10. You're like, well, I know it's there, it hurts me, but it's not so severe, but it's way down to the calf, or down all the way to the foot. That's a much more severe situation in my mind, even if it doesn't feel that way necessarily, And then, of course, we could even talk about people who have just leg pain only, and that's obviously even more worse. Because the worse things get compressed here and irritated, the further down the way they will hurt. Okay? So if we get compression of the nerve at the spine, which is the most likely place it will happen, the more and more pressure that's there, the nerve will hurt further down. You go to the buttock, back of the hamstring, back of the knee, side of the leg, all this stuff. It can't really go anywhere in the leg depending on what nerve is being irritated. It can be in the thigh, groin. I've seen many times over the years men with like testicular pain, stuff like that, that is coming from the back. So those nerves all are in that area too. I'm not a pelvic floor therapist, maybe for obvious reasons, but I would dare say, with my experience with men, that there's probably some pelvic floor pain women out there who have upper lumbar issues, because that's where those nerves are coming from, in women. So probably, like I said, I don't know from experience there. So posture is another big one, okay? So obviously this is a scoliosis, an obvious one there. That person may not even be in pain, Very, very reasonable to think that they don't have any problem with that at all. So not necessarily just because it's there, looking at somebody's back and their curve, scoliosis-wise, that they have to have pain. Not necessarily, could have come on when they're adolescents, which is when it mostly happens. They grow up their whole life with it, never pay attention to it, So, but it could cause pain. The other things up here are bad posture that are not from scoliosis, but just, from standing with bad posture, flat back, or even, it's not necessarily on this one because this is like your normal person, but stuff that we see in the gym is the over lordosis, especially with overhead lifting. Something's really heavy, we're trying to really lock it out, and we get here with it, that can obviously cause pain. I've hurt my own back doing that before, too heavy on push presses and stuff, and trying to get it locked out and end up putting more pressure on my back that way, just from overextending. So centralization, peripheralization. This is kind of like, go back to that quote I was saying, where the pain is located. So this, a much better situation for someone to have localized back pain. Like I said, whether it's really intense or not, the location is really what matters in my mind. So as you go right to left, this is someone's progression potentially of pain that is a bad situation. It's starting in the back, and as that nerve's getting worse and worse, more compression, it's referring further and further away, okay? So we see that, this is stuff that I'm asking people in the clinic. If they have leg pain, I'm thinking it's coming from their back. I ask them, how far down in the leg does the pain go? Or will it go, even if it's for short periods of time? How far will it go? What happens to cause it to go that way? What are you doing when you notice that it's not in the back, but it's also going down to your knee or something? Those are big clues to me, because if we are in this scenario here or here, we want to move someone in this direction. And we want to bring that pain out of the leg and get it back to the back. So if we see that happen, we have a very, very high likelihood of getting rid of the pain completely, because if we see that phenomenon, that centralization. So we're always looking for that in someone who has not just back pain, but leg pain as well, and we're thinking it's coming from the back. So it's another controversial topic. Should you get an MRI of your back? First of all, my opinion on this is that if you are absolutely against having surgery, and no matter what might show up on that, there's really no point to have one, because this is what surgeons look at to identify the target in their surgery. So they're like, okay, we think this person has a big bulging disc at L4, L5, something like that. So they're gonna get an MRI to make sure. So then they can go in and clean up that area around the disc and remove whatever they're gonna do. So that's really what they should be used for, is just to confirm a surgical target. But obviously in this country, it's not that way. They're used very, very commonly just to diagnose people. I don't know how many times over my career, doing this for 10 years or more, hearing people say, well, I just want to see what's back there. I just want to know what's there. I don't want to have surgery, but I just want to know what's going on. But the second point there in that slide is really the problem with that kind of thinking, is that, well, the first and second really, it makes it problematic because they're probably gonna find something. If you have back pain and you're in a certain age group, pretty much at any adult age and beyond, they're probably gonna find stuff. I know there's not many of us here, but even with this group itself, more than likely, most of us, if not maybe even all of us, have bulging disc or something on an MRI if we took it right now, And I don't know about you guys, but I don't have any back pain. But I guarantee if we took an MRI, they probably would see some stuff in there. Or at least, early signs of degeneration. I'm in my latter part of my 30s. I'm probably getting some of that degeneration starting. But that's just a normal part of aging. But, doctors and radiologists and stuff will see it on an MRI and they're like, oh, they have degenerative disc disease. It's not really a disease, we're just getting older. So I hate that they labeled it that way, because now someone with maybe very minor back pain walks out of their meeting with their doctor and they're like, oh my God, I've got disease. I have disease in my spine. It's like, no, you're just 60 years old, like everyone has some by that point, If you live that long, you're gonna have degeneration, not only in your back, mind you. If we took an MRI of your entire body, we'd find all kinds of other stuff, in your shoulders and hips and whatever else, your neck for sure. So anyway, that's really one of the big problems with it, not to mention the cost. So there's been a lot of studies from the folks that kind of run the certification that I have, that I use most often, which is mechanical diagnosis and therapy. They've done a lot of insurance research in the costs behind all this stuff. And so there's several companies in this country that exclusively use this system to try to lower the cost, and they've proven they can do it. And so they've gone ahead of doctors and just talked directly to insurance companies. But anyway, this is stuff that they've found, is that, unless they have these serious symptoms, which is really the only reason someone should be considering surgery, then you're just going to be going to see a therapist, hopefully someone who knows what they're doing and can really get things moving in the right direction. But they're not just coming in, giving everybody an MRI and going to talk to a surgeon. So anyway, like that last slide or last point says there, you would want to make sure, if it is looking like a surgical situation, that the clinical signs match up, and that's where that's all we do. We're all just purely clinical. I'm not, taking imaging. I'm not doing surgery, obviously. So I'm only looking at the clinical signs. Does where this person's leg pain match up with, what the images show in the back? And if they do, now we're looking at, okay, maybe the surgery would be successful. They have this huge disc bulge, it lines up with where the pain's at, but not all the time does it do that. And unfortunately, there's not a lot of clinical exam outside of physical therapists, nowadays. Surgeons just looking at imaging and then scheduling people for surgery. So this is more research on this as far as using the system of classification, matching up with what folks say and complain about, where their pain is, where it goes in their leg, that kind of thing, and identifying people who will benefit from the way that we do therapy. So this is some pictures of MRI that would are showing a herniated disc, a disc bulge. All of those words mean the same thing, by the way. But just taking up space here in this column where this is actually our spinal cord ends up here. So that's what all these are, nerves coming down. So anyway, taking up space. You see over here, we've got wide open room for the nerves to travel, not being impinged, not causing a lot of pain. This is what can happen with a disc. It starts to degenerate, and start that bulging. This is the outer layer, which we call the annulus. It's like a ligament, basically holding in the nucleus, which is the shock absorbing part. That's the blue in there. So that's what everyone's disc looks like on the inside. When that starts to bulge out, of course, it can break through that annulus. Now we're talking problems, because it's likely, well, of course, by then it's probably already been pushing on a nerve, and those pieces can break away and attach themselves to nerves and all kinds of stuff. So not everybody's is going to do that. So I don't like to, I like this slide because it's good, but I don't want you to think, oh, I've got some back pain, or I've had imaging before and they said I have a bulge. Eventually it's going to do this. Now, not necessarily. It could stay at that top picture for the rest of your life, So anyway, there's actually a lot of good research coming out now that folks that have this sequestration, which is just a fancy way of saying the piece of the nucleus, the inside of the disc, breaks away, those folks actually get better faster than people who don't, because the body's immune response is so much more substantial when that happens. So our body goes in there and really, really breaks those things down, and those folks are getting better faster than maybe someone who has this. So something to think about as well.
Is it with or without surgery?
Without. Yep. Yeah, just looking at, I think it was in Japan. They did a bunch of, they excluded everyone from surgery and just monitored they didn't do any interventions. They just had this stuff on MRI and they just went about their normal lives and they just kept checking in with them longitudinally. It was pretty cool. I don't know how they got people to agree to that, but they did.
Did they take imaging at another time
I think,
point?
yeah, they did final. They did some interim ones as well, I think, yeah. Yeah, it was pretty cool. But yeah, they were getting better faster. They ultimately, a lot of them all got back to a similar place, but they were just, some of the ones in the sequestration group were faster. This is just a top-down look of the same thing we were just talking about there, but it includes this middle part here is our spinal cord and the nerves exiting. So you can see why these things happen a lot. There's not a lot of room back there. And so it doesn't take much sometimes to have this start to cause pain. But this is what makes it so tricky, is something like this showing up on someone's imaging, and they have no pain at all. You know? So it varies greatly person to person. You know? So that's why we can't just go by imaging alone. We need that clinical exam, you know, to tie it all together. So this is some more recent research about MDT, you know, using repeated movements to treat back pain. So the highest level research, which is A level, it shows that repeated movements, which is what we'll kind of talk about here in a bit, should be used to centralize leg pain if present, and they can be used to treat acute, which is, you know, like the earlier stages of injury, subacute kind of in the middle, and chronic back pain, even, you know, 6 months to years of back pain. It's showing that people still respond to that. And of course, much more superior treatment-wise than anything passive. You know, TENS, heat, ice, stim, just manipulation, which although it's kind of similar to stuff that, you know, I will do, manual therapy, when it's just manipulation, that is a passive treatment. You know, you're just laying there, you know, getting your back adjusted or cracked or whatever, manipulated. It is a passive treatment as well. So we need that active motion, and that's where that comes in. And this is another recent study about the cost savings of MDT versus just typical physical therapy. So they saved 51.5%, which a lot of that was keeping folks out of getting MRIs and surgeries. You know, that's the most expensive stuff, of course. So if it can be managed in a clinic, and maybe even they, you know, aren't getting injections and stuff like that, but still managed in the clinic, far lower cost, you know, to the whole system than anyone who has to have surgery. So, all right, so obviously it's a very common thing. You can maybe see why. We're not made to sit as humans. You know, we're made to be mobile, you know, people, and with the current way that a lot of us work, you know, we're sitting at a desk for long periods of time, maybe without getting up a whole lot in between. And, you know, then we go home and maybe you don't look like this guy, but, you know, that, you know, we're go home and relaxing, you know, but we're just keeping our back in that similar position for large chunks of the day, not to mention driving in between and stuff. So you can see why it is such a common issue. So yeah, correcting our sitting posture, definitely a big part of what we talk about with this. If we just corrected the posture, maybe it wouldn't take care of the issue alone, but if we're not talking about it or we're not addressing it, then it can really slow that progress down, you know, or potentially just cancel it out. You know, if maybe we're doing the right thing actively through the day, but then we sit like this, we might just be breaking even, you know. So it doesn't really show, it shows like maybe like some lumbar support or something on this chair. They make like lumbar rolls that you would put in the small of your back that really keep that lordosis as best as possible. Potentially could be a good idea if you like the way that feels. What I've found over the years and told people is just take a paper towel roll and put it in the back there in your car or in your chair at work. You've already got it at your house anyway, and you can test it out and see, you know. They make like real dedicated ones, but I found that works really well. It squishes a little bit, but then it stays kind of dense. And, you know, probably not gonna cost you anything else because you've already got one around the house, so. a really good, a good way to improve that sitting posture. So there's some big lifestyle factors, of course, that contribute to back pain. One of them, like we've just been talking about, sitting posture, bad sitting posture, or even, someone who's trying to really maintain good posture, but they just are sitting for really long periods of time. We can't maintain a really good posture on our own. Our bodies are just not made to do it. We can do it for maybe 10 minutes or so. I don't care if you have six-pack abs. It's not gonna protect your back for the long term. So we've got to get up and move around, preferably like every hour, maybe even more often than that, depending on if you're in pain. I sometimes tell people, maybe you have like a stand-up way to adjust your desk or something like that. But sometimes telling people, every 20, 30 minutes getting up and walking around, or doing some standing extension or something. We've got to break that up. The other big thing is how frequently we bend. We can't get away from that. We have to bend. Everything in life is in front of us. We've got to pick stuff up off the floor. We've got to sit. All those things are like bending forward. If we're sitting, it's like you're just doing this over and over. It's like we're just bending our back. So, we bend somewhere around that 3,500 times a day. Maybe even more than that potentially, So, if we think about that, and then maybe what I'm telling someone to do involving extension, either standing or on their stomach pushing up, in a day they may need to do 50 or 60, and that keeps them out of pain. So you can see how resilient our body is, because if it's going to bend that many times, 50 or 60 or maybe even up to 100 or so of the other thing keeps us out of trouble, or potentially could. So our bodies are very resilient. Here are some exercises that we do commonly in this system. Some people need flexion, which is what he's doing here, standing flexion or laying flexion, bending our knees to the chest. Some people do respond to that and need that motion. It just depends on what we find in testing. A lot more people are going to be in this category: extension, standing extension, laying extension, prone press up there, sort of like a push-up, sort of like a cobra position in yoga, where our arms are doing all the work, we're letting our back extend. Far more people are going to be in that group. In fact, that's the most common thing that folks are going to need. Second most common is this: side gliding. We might need something that's moving our back just in one direction, like this. And there's a lot of different ways we can go about that. But if, especially someone who has maybe just pain in one leg, something like, really severe pain in one leg, they may have to spend some time doing something like this before we got to these other things. So most commonly extension. Second place is lateral things, side gliding, where we're just concentrating that motion to one side. And then in last place, but still definitely happens, flexion. Okay. So those are the most common. Now, I might have to get involved in the execution of this as well, manually, adding overpressure, to emphasize what's going on, or maybe progress it. Someone may be able to do a fair job here, pushing up. They're helping the pain, but it's not quite gone. That's where, I would come in and maybe help them with that, once we identify that's really what's needed. So, but getting to end range is important. Getting our back to as far as it can go in these directions. That's where the magic happens. So like I was just saying, it's not just exercises, you're not just doing these things on your own purely. I may have to come in like this guy is here and add overpressure to that movement. She's extending, he's adding pressure at the level where the problem is, making that level extend further. So a lot of times this happens. Of course, every now and then I see someone that just under their own power, they can get rid of their issue very effectively. But more often than not, at some juncture in here, I'm getting involved. But like we talked about way at the beginning, I'm always wanting to get someone back to independence. So if they need me for a certain period of time, that's fine. That's what I'm here for. But I'm always trying to get them back to being able to manage it on their own. So, we may need it, but then we try to back off of it as we go along. I don't want someone to necessarily be dependent on me, have to be dependent on me to get rid of their pain. It's not a great situation in the long term. So, anyway, but yeah, very often does it involve manual therapy. So yeah, what's your directional preference? Well, I was saying, you know, likely it's extension, possibly could be lateral, could be flexion. You know, we don't know. It all involves a mechanical assessment. You know, seeing how you move, see where there's limitations in movement, seeing what aggravates the pain or the symptoms. You know, somebody may not have a lot of pain, but they've got numbness in their leg, or they can't lift their foot like this, you know, or they can't move their big toe, or they can't straighten out their knee. You know, all kinds of stuff like that can happen as well. Weakness. What happens when we move to those symptoms? That's what drives me, you know, not anything particular going into it. We're just purely seeing what happens, you know, in the exam. What happens mechanically? That's what I'm always thinking about. I have a new website name. Still the same website, but I just shortened the name. So that's that. That's my handle on Instagram. Questions about anything we've talked about so far? Try not to make y'all sit too long.